Welcome everyone to the Monash University webinar entitled From the Frontline, Clinical Impacts of COVID-19. I'd like to begin by acknowledging the traditional owners of the lands in which we meet and pay my respects to their elders past, present and emerging. This event is being delivered by the Monash University Sub-Faculty of Translational Medicine and Public Health situated on the Alfred Hospital Precinct. And I'll be your host tonight. My name's Steve Jane and I'm the Dean of the Sub-Faculty. The Sub-Faculty consists of two schools, a School of Public Health and Preventative Medicine and the Central Clinical School. And tonight we'll hear two speakers from each school presenting issues related to this disastrous pandemic. But before we start, I would like to very much acknowledge Shelley Ryland and Emma Taylor, who've worked tirelessly behind the scenes to put the webinar together and to publicise it to the point of we've brought in over 3,000 registrants. So thank you very much to both of them for all their effort. So we are in the midst of an extraordinary pandemic, the like of which hasn't been seen for over 100 years. COVID, a remarkably contagious virus in its most severe form, induces profound defects in many organ systems, including the lungs, heart, nervous system, clotting system, gastrointestinal tract, to name but a few. However, the societal effects of the virus extend far beyond those directly infected by it. And we've seen huge upsurges in community issues, including mental health, domestic violence, financial hardship, job loss, and social isolation. Tonight, we're going to hear from 4 experts from Monash University about diverse aspects of the pandemic and the challenges it has provided to healthcare, clinicians and researchers alike. Professor Jane Fisher will present results of a national survey of the mental health of adults in Australia in the first month of the COVID-19 induced lockdown. Following her, Associate Professor Annika will focus on the adjustment of health services that have had to make in the care of chronic disease, with a focus on multiple sclerosis in her case. Professor Merlin Thomas will then explore the scientific rationale underpinning the search for effective antiviral therapies and vaccines, critically important to us, our ability to defeat this virus. And finally, Julian Elliott will talk about the National COVID-19 Clinical Task Force and Australia's rapid response to create a single trusted voice for assimilation of evidence. Each speaker will present for 10 minutes, and at the conclusion of all 4 speakers, we'll open it up for a question and answer session for 30 minutes, which will take us to a completion time of 7:30 p.m. Questions can be uploaded at any time, either anonymously or with a name, and they can be done via the question and answer feature on Zoom or via YouTube live chat, and will be asked, as I said, at the end of the presentations. I'd ask for you to nominate which of the 4 speakers that you would like to address the question, and to try and focus the questions on the issues our speakers are addressing. There are a lot of questions that everyone is interested in terms of issues related to government responses, quarantine hotels, and a myriad of others. But we'd really like you to try and focus on what our speakers have talked about rather than a broad commentary, which is not really the focus of this webinar. For optimal viewing, I recommend you use the central top view option and then select fit to window and side by side to allow you to see both the presentation and the speaker synchronously. So without further ado, let me introduce our first speaker, Professor Jane Fisher. Jane is the Finkel Professor of Global Health and the Director of Global and Women's Health in the School of Public Health and Preventative Medicine. She's a clinical and academic psychologist who has many claims to fame, one of which is appearing with Ralph Epstein on the ABC on radio's Life and Other Catastrophes program, which I recommend to all of you. Jane's topic for tonight is impacts of the COVID-19 induced restrictions on people's lives and implications for public health and clinical care. Many thanks, Jane.
Thank you very much, Steve, and good evening. We've all had to adjust to really major changes in our daily lives to comply with the restrictions that have been essential to preventing spread of COVID-19. And these have inevitable consequences for our psychological well-being, our mental health. But the nature and the intensity of these experiences is very much shaped by our individual social and economic circumstances. At the time the restrictions were first imposed, there were no national Australian data available about population level mental health to inform the policies and programs that were going to be essential alongside these public health measures. So I want to tell you about some research that we've undertaken to try to elucidate this. So what we aim to do was to try and find out how common and how severe symptoms of depression, anxiety, and thoughts that a person might be having that they'd be better off dead. We wanted to know how common it was to have had a direct experience of the virus, to have lost a job, to be very frightened of contracting it, and to have had an adverse impact from the restrictions. And then we wanted to investigate the relationships between the mental health problems and these experiences. But we didn't only want to examine negative impacts of the restrictions, so we also asked people how optimistic they were feeling. In April this year, we launched a short, anonymous, online self-report survey. Any Australian resident aged at least 18 years was eligible to participate. And it included two well-used questionnaires which ask about symptoms of depression and which ask about symptoms of generalised anxiety. In total, during the month of April, nearly 14,000 people contributed data to this survey. And they came from all Australian states and territories. There was population representation of people who don't identify as either female and male, as well as women and men. The samples spanned the entire adult age range, and they came from all socioeconomic positions. At that stage, relatively few people had actually been diagnosed with COVID-19, but more of them had been tested, and quite a high proportion were actually living with or knew someone who had been diagnosed with the virus. 1 in 10 had lost a job because of the restrictions, and a proportion of people were highly worried about contracting the virus, but by no means at that stage the whole population. But 1 in 4 said that the restrictions had had a highly adverse impact on their lives. Because the whole population had been affected, there was no direct comparison group that we could turn to in the Australian community. So what we did was turn to existing studies that had used these same questionnaires in other high-income countries where they'd randomly selected people from the general population. And what this column shows you is that the estimates of moderate to severe symptoms were between about 4 and 11%, of anxiety about 6%, and of thoughts of wanting to die or of contemplating self-harm under 2%. But what we found was that at this time in Australia, among the people who completed the survey, more than 27% had severe, moderately severe symptoms of depression, 21% symptoms of anxiety, nearly 15% had had thoughts at least some of the time that they thought they'd be better off dead. And 1 in 4 told us that they were feeling more easily annoyed, more irritable, especially in their interactions with family members. It wasn't only the severe end of the spectrum that had changed. And what we found was that a high proportion of people, 1 in 4, told us that they were experiencing at least mildly elevated depression or anxiety symptoms. But it was reassuring that 28% still told us they felt highly optimistic. What this shows is that there was a significant relationship between every experience and every mental health outcome. But I want to draw on two examples to illustrate this because the table is too complex to make meaning of in a short time. What this tells us is that among people who had lost a job because of COVID-19 restrictions, they were 50% more likely to have clinically significant symptoms of depression than other people. Among people who told us that the restrictions had had a very adverse impact on their lives, there was more than double the likelihood that they would be experiencing thoughts that they would be better off dead or of self-harm. So what these represent is an overall population shift in mental health, with marked increases in both mild and severe symptoms. In the people who participated in this survey, those most likely to have moderate to severe symptoms had lost their jobs, were living alone, or in the least well-resourced, the most disadvantaged areas, or were providing care to young children or to dependent family members. All were members of marginalised minority groups, and more of the people with all these experiences were women, and more of them were young. So it might be reasonable to ask, well, why does this matter? We had to take very serious action to prevent the adverse consequences of the virus. They matter because they contribute enormously to people's capacity both to live through this experience and to recover from it. So with people with these mental health problems don't function so well. Their volition, their drive and enthusiasm and vigour is reduced, and their capacities to problem solve, plan, organise and concentrate are all diminished, and they have less capacity to engage with others. But I think what these data challenge us to think about is that it's not helpful to label this, in our opinion, as a psychiatric illness. They've arisen rapidly in clear response to a particular circumstance. And I think they're more helpfully conceptualised as a normal human reaction to very abnormal circumstances, and that these have challenged our individual capacities to adapt. And they've also really restricted our access to things that are protective, interactions with friends, family members and colleagues, and our opportunities to participate meaningfully in economic activities. Anxiety is usually increased in circumstances where we experience uncertainty, and we've all had to live with uncertainty. We've found it difficult to understand the evidence underpinning some of the recommendations, and there's been as yet no end point that we can plan towards. People are most likely to experience depression or low mood when they feel humiliated and trapped. And there could be no more evocative example of this than someone living alone who's lost a job and has to plan how to address these circumstances on their own. I think other helpful psychological constructs are the constructs first of disenfranchised grief, which is the experience we have when we've lost something important to us, but not at the level of a bereavement. So we've all lost to some extent autonomy and liberty. Many have lost essential family events that they've been unable to participate in. People have lost meaningful activity, the things that are very important to their lives. Demoralisation is experienced when we feel helpless and when we're in a predicament that we can't influence. So together, we've needed a public health approach to manage the impact of the virus on the community and society and on the health system. What I argue is that we now need a public approach to mental health. And while it's very important that this is partly located within the health sector, I think it needs to extend well beyond that. We need universal health education and health promotion for the whole population. Some people will need lowest intensity assistance, forms of self-management, access to online resources, and a smaller group will need high intensity services. But I think it's an opportunity for us to think about task shifting to the non-health sector. So building the psychological capabilities of people in community services, in employee assistance programs, in the workforce sector, so that they too are able to respond helpfully to people's mental health needs, psychological needs. So the government's investment in telehealth and telephone helplines has been of great value. We don't want to diminish that, but I don't think it's going to be sufficient. These data definitely tell us that it will be valuable for primary care practitioners to assess the mental health of people who are in the more vulnerable groups, in particular those living alone or who've lost jobs or who are carrying a high burden of unpaid caregiving. Others are using these data to explore other factors like the access to non-COVID related healthcare and the impact of mental health on excessive use of alcohol and on overeating. And these will be released as the analyses are completed. But I would like to acknowledge the contributions of my colleagues who've contributed enormously to this research, to the people who contributed their data to enable us to understand this, but also to acknowledge the enormously valuable philanthropic support that has enabled this research to be completed. My chair is supported by a very generous philanthropic donation from Elizabeth and Alan Finkel to Monash University in the field of global health. This particular project was enabled by an untied and very generous donation from Professor John McBain and Dr. Penny Foster, to whom we're enormously grateful. If anyone listening is willing to fill in the second survey, which is seeking to understand people's experiences now as restrictions are lifted in some places and strengthened in others, please go to Monash, Living with COVID-19 Restrictions, and we would be very grateful for your input and your contribution to our list of potentially helpful responses from government that we are wanting to use to inform policies to assist recovery of mental health among adults in Australia. Thank you.
Thank you so much, Jane. Our next speaker is Associate Professor Annika van der Walt. Annika is a clinical academic neurologist who leads the Alfred Hospital Multiple Sclerosis Neuroimmunology and Neuro-Ophthalmology Services, and also a researcher of note in the Department of Neuroscience in the Central Clinical School. Importantly, Annika plays a leading role in an international collaborative study examining the effects of COVID-19 in patients with multiple sclerosis, which stems from an enormous database housed in Melbourne, the MS base, which holds data on over 70,000 multiple sclerosis patients from over 36 countries, an enormous achievement. Annika tonight is going to talk on the impacts of COVID-19 on clinical care and service changes. Thanks, Annika.
Thank you. Thanks, Stephen, and thanks for the opportunity to speak tonight and tell you about my experience during the pandemic. I'm mostly wearing my clinical hat as the head of service for MS and neuroimmunology at Alfred Health. And I'm also hoping to provide you with a bit of a taste of the data collection efforts that we are involved in. I think that the chronic diseases and the care of chronic diseases has very much continued in the background with a massive adjustment in the services and the way we deliver services And some of these things may truly continue and change medical care for a very long time, if not permanently. So I think it would be quite appropriate to many of the medical specialties that some of the listeners might be familiar with. So as an introduction, I guess, what is multiple sclerosis? So multiple sclerosis is an autoimmune disease of the central nervous system. And this is characterized by attacks of demyelination that presents with clinical symptoms, and that is measurable on an MRI scan, which is pretty much our favorite test, with very typical lesions appearing in the brain that you can see on the left here, and also in the spinal cord. It usually affects people in the prime of their lives between the ages of 20 and 40, but it can happen to anyone at any time. The clinical course of the disease is very heterogeneous. So it really is different for everybody. But there are certain characteristics, such as a relapse, shown here in this little blue bar, that really heralds the onset of clinical disease and the start of ongoing relapses for many people that can fully recover or not fully recover over time, leaving people with a little bit of disability over time. Over decades, we see that relapses become a bit less frequent, and we see the onset of slow progression and accumulation of disability, which is not really amenable to any treatment or intervention, which is when people start to struggle a little bit more and develop some neurological symptoms, the so-called progressive phase of the disease or secondary progressive disease. And for some people, they only present with progressive disease with some activity or without. So when we think about care of multiple sclerosis and people with multiple sclerosis, I think the main thing to note is that it's a very treatable disease. So we're very lucky in Australia that we have we have 12 treatments approved and funded through the PBS to treat MS and to prevent progressive disease in particular. So healthcare for people with MS is very much targeted towards maintaining health and is delivered as outpatients. So patients would present to the hospital, they would see their neurologist, usually at least twice a year for about 15 or 30 minutes at a time, sometimes longer. And this is pretty much the hallmark of many chronic diseases and how we look after people. In MS, there's some of the treatments that we deliver is through intravenous infusions, and this requires people to have these regularly and on an ongoing basis, which requires access to infusion centers and hospital resources. There is a huge amount of monitoring for subclinical disease. We also monitor for safety and look after people in terms of long-term side effects as well. And I think something that we have to take into account when we think about service adjustment in the pandemic is that there is also the long-term effects of disrupted care that we need to consider and plan for. So what do we do then when routine care suddenly becomes a scarce resource, which is exactly what happened, or otherwise what we sort of thought in panic? How on earth are we going to continue looking after about 1,000 people at least under our care and keep them safe while we are facing major disruptions in the resources that we generally take for granted? So neurological care was obviously compromised by effects of being in lockdown, quarantine, physical distancing with people not allowed to aggregate in waiting rooms, for instance. And this required a lot of innovative thinking about how to continue the care of people with chronic conditions. And this was especially in about mid-March, very much dependent on flattening the curve and also modeling, which we realize, of course, can be flawed and things can change just when you think you're over the worst, as we've all found out. And then largely, we were initially completely working in a data vacuum, which we really had no idea what would happen to people with MS that we treat with immunosuppressive and immunomodulatory type therapies, and if they should get this infection, what would happen. So basically, we went to having no outpatient care. We did not want people to come to the hospital. We were faced and notified on I still remember a very distressing Wednesday, where we were told we have 2 weeks and then we will have no more infusion centres at the Alfred because it was being turned into an ICU. We could not access routine MRI scans, and lab services, laboratory services were disrupted. And this, of course, we still not know what's going to happen long term. So I guess if we think about it, firstly, one of the main things we faced was our routine care. So could people still see their neurologist? And this was a big question that came up. And there was a very rapid shift to telemedicine, which was a truly remarkable change in the way we deliver care. And at the Alfred in particular, we were already quite set up with this, and we were already delivering some telemedicine, but not very much. It of course has advantages and disadvantages. The advantages being that it was validated already in MS, so we could deliver rehabilitation and care through video, and there was some basis in literature to support this. It was, of course, much safer, so we would be protecting healthcare workers, but also patients from coming in and perhaps getting infected in healthcare situations. And it is, of course, very convenient. So people could have it at home. It's convenient for clinicians, and also for, and again, we could deliver some of our therapies through this portal as well. However, it's just not the same. And I have to say, I'm having quite a bit of withdrawal from seeing my patients in person. And I guess the hallmark of neurology is that it's very much a clinical science, or an art form, we would prefer to call it. And you can't really, examine anyone, and it's difficult to assess relapses properly. There's lots of issues around data privacy and IT infrastructure, and the need for consent for anyone who is having a telehealth consultation. We could, of course, not perform any of our clinical research, which we routinely perform in clinic situations. And it created quite a lot of an admin trail, with prescriptions having to be mailed and so forth. But overall, we've overcome most of this through health systems that's adapted to this. What about the infusion center? So the dreaded time in mid-March, when we were told that our infusion center was being shut down and that we would be scaled down to pretty much a third of the usual capacity that we had. So we had several options facing us. We could either, change the intervals between the infusions, so space them further apart in particular. We could give it faster potentially, so speed it up a little bit and see if we could basically fit more people into the same resources, or change the location of the infusions. So firstly, in terms of changing the intervals, so again, there's definitely some basis for this in science and literature, with natalizumab, which is a monthly infusion, usually, that can be given perhaps on an extended dosing interval, 5 to 8 weekly. We know that the half-life of the drug is about 16 days, but the biological effect of the medication will generally persist for about 2 to 3 months, after which there is a significant relapse or very severe disease reactivation that can be life-threatening. And we know that there's some studies supporting that this could be effective if you space the doses further apart. With ocrelizumab, which is an anti-CD20 therapy, which we commonly use as well in the MS world, this is usually given as a standard 6-monthly ongoing treatment, and we thought that, and this could also potentially be extended. The half-life, again, does not necessarily correlate with the biological activity of this medication, which is often active for 6 to 12 months after the last dose, or even longer. The problem being that the recovery of these cell populations that then will drive attacks of the disease can be quite unpredictable, and it can be very inconsistent. So there's quite a significant risk that if we get it wrong, we could trigger relapses. So the thing that we found a bit more interesting to do was perhaps to change the speed and the rate of these infusions. So with natalizumab, we looked at increasing the standard infusion rate to basically, instead of giving it over an hour, to give it over 30 minutes. And with all the, booking times and getting someone settled in a chair and observation periods, it really would save us about 30 minutes per person to do this. We've now given actually over 200 of these infusions, and we've been able to demonstrate only a 5.8% infusion reaction rate, which is actually much lower than seen in the pivotal trials, where the infusion reaction rate was about 24%. So patients are tolerating this quite well, and all the reactions have been pretty mild. With ocrelizumab, again, we shortened the infusion rate from 3.5 hours to 2 hours. And the booking time here was significantly reduced from 350 minutes to 250 minutes. So you can see a significant saving there in terms of the use of resources. Again, things have been going really well with this, and the infusion reaction rate is sitting at about 12.3% at the moment, compared to what was reported in the pivotal trials of more than 30%. So it certainly appears to be very well tolerated and safe. I think this required an enormous effort by the pharmacy team, by the Drugs and Therapeutics Committee, and our nursing staff to manage these infusions and collect the information. In terms of location, giving an infusion at home might be feasible, particularly with natalizumab, which is clearly a much faster infusion. The problem, of course, and this is something that we've just rolled out in the last week, was around things you wouldn't normally think about, like funding models of drugs, IV access. A lot of people who would have therapies at home would have permanent lines in which people with MS would not have. Who would be responsible for safety if something does happen at home, and we had to adapt our service to be responsive to this. And then, of course, the biggest delay was actually getting a fridge in the car and an esky. So there you go. But we managed to get this up and running as well. So the long-term effects of all of these changes in care, I think we still don't know what this is going to be. And I think this is definitely going to be, the future waves of problems associated with this virus. There's a real risk of inadequate treatment. And I think that we don't know what happens outside of tertiary health facilities. And there's a real chance that clinicians might choose less effective therapies or delay starting therapies for too long, which can then harm people in the long term. There's also a big disruption with health maintenance, and this is something that has particularly come to the front with the second lockdown in the last few weeks, with people not being able to access their NDIS programs or rehab programs. And loss of function in this context can take years to regain. And there is also clearly not adequate safety monitoring, and we may be missing safety events and only seeing people when things get really severe. And as Jane talked about before, the mental health impact would be huge in people who are already quite vulnerable to mental health problems. So in terms of filling the data vacuum, so we've been involved in several efforts. Firstly, I guess, nationally and also internationally with our colleagues in New Zealand. We have been coordinating through the Australian and New Zealand Association of Neurologists Interest Group, a rapid data collection platform that's run at Monash University at the Central Clinical School. The information that we know clinically has also been provided very much by International Women in MS, which is, we are proud to have some of the executive housed at the Central Clinical School with Dr. Villa Jokobaitis, which organised these meetings with a very rapid sharing of international experience of these infections in people with MS. And then globally, as Steve maybe mentioned, we are collaborating with very big data groups, the MS International Federation and MS Data Alliance, as well as driving our own research through MS Space, which is the home of MS Space is also the Department of Neuroscience in the Central Clinical School, where we are currently collecting data on COVID-19 infections in MS. But the greatest need really has been the managing the phone. And I have to say, without our dedicated administrative and nursing support, things would have fallen apart pretty badly. There was an overwhelming number of phone calls initially, and I was very concerned for our staff and their well-being, with having to provide information when we actually just did not know what was going to happen. And I guess in lockdown 2, we've now been flooded with a different type of phone call, with a lot of people wanting exemptions, people worried about losing their NDIS support programs because these programs can't run at your house, and financial distress, of course. Communication strategies has been very critical to inform patients. So I guess to summarize, I think, if we think about the saying about everyone who wants to innovate, but nobody likes to change, which is generally quite true in healthcare. We generally are very slow to change. I think in this case, it was really not true. And we saw an enormous change in the way we deliver chronic healthcare, and I think many of these changes will persist to the benefit of our patients and our healthcare workers. So it's important to maximize these benefits as much as we can. And I think balancing risks and benefits will remain critical, because for most patients with MS, for instance, a relapse will be generally much worse than the actual contracting the infection. I think it's important to never waste a good crisis, so to be responsive to evidence and research, to change guidelines if it's needed, and if you can do so safely, while you get more evidence to support that. Communication is clearly key, and our main duty was to try and keep our patients away from emergency departments, and to try and limit the burden on the first line forces. And then very importantly, you will really get nowhere if your team falls apart, and it's really critical to support each other and stay connected. And with that, I'd just like to thank our lovely MS and neuroimmunology service, Louise Rath, Janine Riches, and Kelly Leakus in particular, Prof. Helmut Butzkieven, and the Alfred Brain Executive led by Terry O'Brien, and then the staff at the Alfred and all our patients for their enormous resilience and patience during this time. So I'll finish there.
Great, thanks so much, Annika. So the next speaker is Professor Merlin Thomas. Merlin's a clinician scientist who heads the Biochemistry of Diabetes Complications Laboratory in the Central Clinical School. Merlin is a renowned researcher and educator, but he's also an extremely well-published author with 2 very good books that I would recommend to you, The Longevity List and Fast Living, Slow Aging, both a good read. He's recently been the recipient of a very large federal government grant towards a new inhalable therapy for COVID-19. And Merlin's going to talk to us tonight about how the world is going to find a solution. Thanks, Merlin.
Thanks, Steve. Hello, everybody. I'm Professor Merlin Thomas from the Department of Diabetes here at Monash University's Central Clinical School. I know there's a lot of doom and gloom going around, but what I really want to tell you is that there is going to be a smart solution to COVID-19. Tonight, I'd like to briefly explain some of the new strategies currently being formulated, including some here at this precinct, and the innovative science behind them. The rapidly expanding knowledge of the virology of SARS coronaviruses has laid the groundwork by providing potential drug targets. We now know that the virus enters our body using the spike protein on its outside. These surround the virus like the spiky corona of the sun, and hence the name coronavirus. This spike protein selectively sticks to ACE2, a protein that sits on the surface of cells lining the respiratory tract. ACE2 is a bit like a doorknob. When it gets grabbed by the spike, it opens the door to the virus. This triggers a cycle of virus internalization, replication, release, and reinfection that serves to progressively increase virus load. Significant viral shedding and potential transmission begins after a couple of days of virus buildup, and symptoms generally begin 2 to 3 days later as virus loads peak. Generally, the more virus you have inside you, the more severe your disease. In terms of preventing COVID-19, vaccination is Plan A, currently our best bet for future control and ultimately an end to this pandemic. A vaccine is a type of medicine that reprograms our immune system so it can effectively fight a virus that's not come into contact with before. And this is known as immunity. On an individual level, immunity can reduce the risk or severity of illness and resulting complications. On a population level, mass vaccination is the only way to safely achieve herd immunity, to prevent virus spread or eliminate it entirely by giving the virus nowhere to go. Immunization is widely used to prevent or reduce the severity of common viruses like measles, chickenpox, and influenza. A vaccine works by triggering a protective immune response that means if ever you're exposed to the real deal, you'll be primed and ready to defeat it. Dozens of vaccines against COVID-19 are currently in development. Of the 26 that are in clinical evaluation, all are aimed at inducing a protective immune response directed against the ACE2 binding domain of the virus spike protein, which the virus uses to bind and enter host cells. Some of these vaccines inject actually only the spike protein, and these are called subunit vaccines, as they use smaller pieces of the virus or subunits to trigger a protective immune response. For example, the seasonal influenza vaccine we all have is a subunit vaccine. These subunits are generated in the laboratory, so there's no live virus involved. The University of Queensland's molecular clamp stabilised spike, and South Australia Vaccines COVAX-19 are some examples in development. Subunit vaccines often require several doses and the use of adjuvants. Adjuvants provide signals to the body to safely boost the immune response to the subunit by making the subunit seem a bit more dangerous than it really is. Some vaccines in clinical development in China use coronavirus that's been completely inactivated, for example by formalin, commonly used for fixing and preserving dead tissues. Some of the potential vaccines against COVID-19 also use a harmless virus known as a vector to present the spike protein to the immune system. For example, the University of Oxford's and AstraZeneca's vaccine use a vaccine using a chimpanzee adenovirus expressing the spike protein. Finally, some new vaccines work by injecting genetic material coding for the production of the virus spike protein in a muscle, instead of being assembled into a virus. Just the subunit is made in each of these situations and then presented to the immune system. The most advanced of this is the Moderna vaccine that uses synthetic lipid to deliver a nanoparticle to deliver the coding templates. Despite their differences, and in the end, all these strategies just hold up the spike protein to the immune system to train our body to recognize the enemy and show it off if ever we meet it again. Notably, neither the vector or the genetic approaches have ever been previously used in licensed vaccines to prevent infections in human beings. However, these strategies are now central players in the US Department of Health and Human Services so-called Operation Warp Speed that aims to provide mass vaccination in the US by January 2021. Obviously, this is not going to be easy, safely treating millions, if not billions, of healthy people. We still don't know what protective immunity in the lungs actually looks like, and whether enough immunity can ever be achieved to stop you becoming seriously ill using a vaccine strategy, even those that trigger the development of antibodies. So it's critically important we have a plan B as well as a plan C and a plan D. One idea is that you could make a new treatment, but just for those who test positive for the virus, with agents that could reduce the severity of illness. With COVID-19, many cases don't have any symptoms or only have mild disease, and this wouldn't matter so much or even need to be eliminated as long as you could rapidly and effectively treat any severe illness or high-risk individuals. For example, Relenza and Tamiflu are antiviral medicines used to treat influenza. When taken within 48 hours of the first symptoms of infection, it can reduce the symptoms and make them a little bit less severe or shorten the recovery time. And this is why they got stockpiled in recent influenza outbreaks while the world waited for a new vaccine. Of course, these won't work against COVID-19. Antiviral therapies are specific for a particular virus in most cases, and this is different to antibiotics like penicillin that can be used to treat different illnesses because they can kill different bacteria. However, a number of different antiviral therapies are currently being developed to treat COVID-19, including remdesivir, which was originally developed to disrupt another virus, Ebola. A number of groups are hoping to design or identify a novel coronavirus-specific antiviral therapy. For example, Tom Karagianis from our department recently used computer modelling to identify a chemical that blocks one of the proteins needed by a coronavirus to replicate itself. Another idea is to use antibodies to fight the virus in severe cases. Of course, these are in high levels in people who have previously had infections, so coronavirus neutralizing antibodies taken from their blood or recombinant versions made in laboratories might work as a short-term fix, and this is called passive immunization. Recent data suggests that cross-neutralizing activity may actually already exist in some people or populations due to exposure to other benign coronaviruses. So trials are also looking at pooled immunoglobulins taken from thousands of donors as a potential treatment for severe cases of COVID-19. Another strategy is to alter the inflammatory response in patients with COVID-19. This is because it's now recognised that the host's inflammatory response to a coronavirus infection or the damage that it causes can trigger a dysregulated host immune response in which the lungs and other organs can become collateral damage. This is sometimes called a cytokine storm, although many other components of the immune system are also out of order. And we know that there are many drugs that can dampen the immune response. The best known of these include steroids like dexamethasone, which has already shown some benefits in severe cases of COVID-19 in the recovery trial. But it's not a cure-all. Importantly, there was no benefit and possibly some harm among patients with shorter symptom duration or lesser disease severity. And this is probably because you need your immune system to fight the virus, just not to fight you at the same time. Treatments more selectively targeting parts of the immune system, including IL-6 inhibitors and the IL-1 inhibitor anakinra, are also currently being studied in severe COVID-19. But the concern remains, will they inadvertently dampen the host antiviral response while quietening the cytokine storm? Sometimes ideas come out of left field. In February this year, we were actually working on ACE2 and its role in the complications of diabetes. And then we suddenly found that this new virus had hijacked our favourite target. But within an hour, we'd formulated a new way to take it back. Our strategy alters ACE2 and how it's processed in the lungs. Instead of making full-length ACE2 that sits on the cell surface and bind coronaviruses, we've discovered a way to reprogram cells into making a short form of ACE2 that floats free of the cell surface, so it can't be used by the virus as a doorknob to get inside. So less surface ACE2 means less virus getting in, and so the virus load goes down. In addition, this short ACE2 still binds to the virus, so it can act like a decoy to stop coronaviruses from getting into other cells. And this treatment can be simply inhaled so that only the ACE2 expressing cells lining the airway are affected. In other words, just the cells vulnerable to virus infection. The idea of this treatment is to slow the virus down and give the immune system more time to do its job. This work is currently funded by the MRFF antiviral scheme and is currently being tested in animals. But if it works as well as we hope, the first studies in humans are planned to start next year, so watch this space. But in the meantime, even though you're in lockdown, you should know that scientists here at Monash University and around the world are actively working towards a smart solution for COVID-19. I'm going to now pass you back to our moderator, Professor Steve Jane, but if you have any questions, there will be a forum at the end of the symposium. Thank you.
Great, thanks so much, Merlin. So our final speaker tonight is Associate Professor Julian Elliott. Julian is Executive Director of the National COVID-19 Clinical Evidence Task Force, a very important role based at the Cochrane Centre in the School of Public Health and Preventative Medicine. And Julian is also an infectious diseases physician at Alfred Health. His topic tonight is Confusion and Controversy in a Global Health Crisis, Australia's Rapid Response to Create a Single Source of Trusted Evidence. Thanks, Julian.
Thank you, Steve. So tonight, I just want to describe briefly this journey that we're on from confusion to clarity. We've been working to make sense of COVID-19 research for Australian clinicians. So to just set the scene, even before the COVID-19 pandemic, as clinicians, we've often been overwhelmed by the amount of research available for any given clinical question. And as colleagues and I pointed out in an article now several years ago, unless we invest in the systems that can find, synthesize, and summarize all of those scientific studies relevant to a particular question, to provide a kind of compass or guide so we know how to treat and manage our patients, then we have an increasing risk that as all of this research volume grows, we'll be buffeted by the claim and counterclaim of individual studies. And so inadvertently, this can contribute to confusion and controversy. And I think all of us would agree that as we've entered this pandemic, we've certainly entered a period of confusion and controversy. We've seen this astounding flow of claim and counterclaim, breakthroughs, cures, magic bullets, publications that have then been retracted to be found fraudulent, a constant flow of miracle drugs in press releases. We've even had to consider whether it might be beneficial to drink bleach or disinfectant. Who would ever have guessed? And so as clinicians, we are influenced by and connected to those wider discussions in social and general media, but also within our own expert communities, particularly early on in the epidemic, there was this flood of conflicting expert recommendations, at times very strong recommendations that we should use a particular treatment like hydroxychloroquine or follow a particular management path. So for example, for pregnant women with COVID-19, that they should have a cesarean section or that they should not breastfeed or that they should not sleep in the same room as their newborn baby. So there was this rise very quickly of conflicting recommendations, which in those first few weeks was really contributing to confusion, controversy, and unfortunately also contributing to the rising anxiety that healthcare workers are feeling. And so by early March, a number of us felt very strongly that Australia needed a rapid response to create a single source of trusted evidence. And so we moved very quickly to establish the National COVID-19 Clinical Evidence Task Force to produce national guidelines for the clinical care of people with COVID-19. And we're very fortunate to have a rapid response from our funding partners, Australian and Victorian governments, the Ian Potter Foundation, Equity Trustees, and the Lord Mayor's Charitable Foundation. And so with their support, we were able to establish the task force. And I now just want to describe some of the key characteristics so you can understand how we're addressing this problem of confusion during the pandemic. So first of all, the task force is a consortium of 29 national peak clinical groups who have come together to speak with one voice. So we have the hard discussions, we grapple with the difficult decisions, and we do that together so that we can then speak clearly and consistently to Australian clinicians and provide guidance and reassurance so they can provide the best possible care for people with COVID-19. Secondly, we've had an extraordinary contribution from across Australia's clinical communities. We now have over 200 clinicians who, despite all the pressures in their clinical work dealing with the pandemic, make time every week to come together to review the evidence and have at times very difficult deliberations and make recommendations for their peers, for clinicians around the country. Thirdly, we use very rigorous methods. We use the science of systematic review of evidence-based guideline development that has been developed over the last 30 years. So we hasten slowly. We move quickly, but we don't cut corners. And that's a fundamental foundation for the trust that clinicians can have in our guidelines. Now, in this, there's a real challenge, because until recently, to use those high quality, rigorous methods has required an extraordinary amount of time and resource. So typically for guidelines such as ours, they might take a year or 2 years to be developed and might be updated every 5 years. Clearly, that's no longer appropriate, even before COVID, with the daily flow of new research. And so there is this trade-off between quality and currency of our evidence and guidelines. We can use these very rigorous methods so that we can trust in the evidence and guidelines, but we can't keep it up to date with that flow of new research. Or alternatively, we can grab very quickly, skimming across the surface of science, kind of science by Twitter, kind of roughly getting an idea about what the science is saying. We're wasting a lot of that research in that method, but we are keeping some degree of currency in that kind of summary. But we know that that is flawed, that in using those practices, we are then open to bias, inaccuracy, which impacts patient care and ultimately health outcomes. So this constant trade-off between rigor and currency. So in recent years, we've been working to break this trade-off so that we can have evidence and guidelines that are trustworthy and up to date with the latest research. So working with the wider Cochrane community and within the Australian Living Evidence Consortium with a number of partners, we've been demonstrating through proof of principle projects our ability to break this trade-off. Initially creating the first national living guidelines in stroke, and more recently, national living diabetes guidelines. The way we do this is by utilizing a number of innovations, including digital platforms, machine learning or AI to help us sift through that global evidence base, and also crowdsourcing through a platform called Cochrane Crowd, where we draw on the contributions of people around the world to do some of the core tasks in systematic review. So using all of these processes, we've been able to cut the time for updating a national guideline from somewhere around 5 years down to monthly updating, so a 95% reduction. But the challenge in COVID-19 is that there is an even greater flow of research. So even to date, there have been 15,000 studies published. And we estimate that by the end of the year, there'll be 35,000 published. So with this volume of research, and of course, with the incredible importance of keeping absolutely up to date with the latest research during this pandemic, we have moved now from monthly updating to weekly updating. So how does this play out in practice? We have an extraordinary evidence team, very experienced people who are searching globally for all research relevant to COVID-19. They use that research to create very high quality summaries of the evidence, what we call living systematic reviews and evidence profiles. They are then presented each week to our expert clinical panels and other working groups and advisory groups who review the evidence and then create evidence-based recommendations that are then submitted to our peak clinical group, the Guidelines Leadership Group. And every week, with additional input from the consumer panel and guidance from our Conflicts of Interest Committee, produce and confirm guideline recommendations that are then submitted to our steering committee. We then approve with further discussions, sometimes with our colleagues in government. We then each week publish our updated recommendations on a Thursday afternoon. So that weekly cycle continues whilst at the same time being underpinned by those high quality processes. And so to date, we've created 60 living recommendations and 5 living clinical flowcharts across a broad range of clinical areas, tackling important and controversial topics such as drug treatment, drugs like dexamethasone, remdesivir, hydroxychloroquine, the appropriate use of oxygen therapy in different settings, the initial assessment and management of people with mild, moderate, severe or critical COVID-19. And for pregnant women, guidance that they can choose their mode of birth, that they can breastfeed, and that they can sleep overnight in the same room as their newborn baby. Our recommendations are published each week on our website. And so far, we've had great interest and uptake from clinicians around the country. One of the advantages of this living model is that we can be responsive to the questions and the issues of clinicians. So clinicians, by submitting their questions through our website, really shape the focus and the priority of the task force. And it's their questions that really direct where we put our efforts. So for any clinicians who are in the audience, I really encourage you to come to the website, submit your questions, and sign up for our weekly updates. So in closing, I really want to thank very deeply all of our partners and funders. I want to call out specifically the Consumers Health Forum of Australia, who've been a fantastic consumer partner for the task force, NPS MedicineWise, who are enhancing our knowledge translation activities, and important government partners such as the Australian Commission on Safety and Quality in Healthcare. But I really want to highlight the contribution of all of our clinicians, now over 200 clinicians, who, despite all the challenges that they have in their daily work, are giving up time every week to produce evidence-based guideline recommendations, making an incredible contribution to the task force. But more importantly, a contribution to their peers, to clinicians around Australia, so that they can provide the best care possible for people with COVID-19. Thank you.
Thanks so much, Julian. And just again, I'd like to thank all 4 speakers for some superb talks, giving us different aspects of the effect of this pandemic on the health system. So we're now going to move into our question and answer sessions. We've been inundated with questions and I'll try and spread them equitably across the group. And I'll start with you, Jane. If I can just make sure I've got the times. I haven't. So Jane, a question for you. Considering the effects of the pandemic on different cultural and linguistic groups, how important is the concept of transcultural mental health and how will delivery of services change because of this, do you think?
Look, I think it's an excellent question. I think one of the things we've learnt is that the diverse needs of people who speak a language other than English and come from different cultural backgrounds have not been understood as well as they should be. So any mental health response has to be transculturally informed. And in my opinion, this requires active consultation with wide communities and co-development of any response that is provided by governments and by other agencies.
Great, thank you. Annika, for you, somebody's very interested to know what care of chronic conditions looks like post-pandemic. What lessons have you learnt from the pandemic that you think, boy, that's a great iteration. I would like to hang on to that to look after my patients once this all reverts back to whatever normal is?
Thanks for that question. I think this could be, some of the silver lining to this whole crisis that we're in, is that we're seeing a real change in the way we deliver care. And I think some of these changes have really been for the good of all of us. I think what I would expect to persist would really be the increased use of telemedicine. And I think that we will hopefully continue to see that used much more widely than it has been in the past. And for us to use it much more innovatively to connect clinicians with each other, connect multidisciplinary teams with each other, and also give us the ability to actually assess people perhaps even in their own environment. So it opens up huge amounts of research avenues as well, of course. The other thing I think would be that I'm hoping that we'll see a much more efficient use of resources as well, so that we will see more, more trying of new infusion protocols and adapting protocols with a bit more flexibility. So yeah, lots of changes that I hope will, be there for the long run.
Okay, great. Thanks very much. Merlin, a fairly common question is, I think, a degree of concern about the ability of the sector to generate billions of doses of vaccine and where Australia sits in the hierarchy of that.
And those are really important questions. And in fact, one of the first questions, even before these vaccines have been studied in clinical trials, is how can they be used by real people in the real world and delivered by essentially real doctors and nurses. And that was the fundamental requirement for all of the drugs that are currently in Operation Warp Speed and subsequently in other ones. They had to come into it not with just a drug that worked, but also one that would provide capacity for generating large amounts of product. And you can see very clearly that very large pharma is behind it. They have enormous capacity to generate these things. And I think it will be possible. The real question is it going to work? Is it going to be effective enough? And will the uptake be sufficient to achieve herd immunity to the point that we can slow this virus down?
Okay, thank you. Julian, a fabulous question here for you. Given the fast tracking of publications now into some of the leading journals, how does that impact on your ability to provide accurate evidence-based assessments with the possible lessening of peer review scrutiny? We've already seen some major papers retracted, not that that's never happened before, but things certainly seem to get to print faster than they were before. So does that come into your consideration?
Yeah, so I think this question is really about the use of what's called preprint servers, which is a way of publishing research before it has been reviewed by others in the scientific community, what's called peer review. So I think it's important to realize that preprint servers have actually been around for many, many years in other fields. So for example, astrophysics, high energy physics, mathematics, it's a very well-established way of disseminating research. It has been around for some time in health, but it's certainly in COVID-19 that it's really gained momentum. And I think it definitely does have benefits in terms of giving the world earlier access to important scientific information, but it has to be with the caveat of understanding the risks of those data. So it's like a buyer beware. So if we carefully understand that those data being presented in the publication have not yet been through the peer review process, then we can use those in a way that builds in that caveat. So for example, in the task force, we do look at data presented in preprints, but it may, for example, temper the strength of our recommendation. We may make a conditional recommendation rather than a strong recommendation, pending the full publication of the peer-reviewed research.
Great, thank you. Well, I don't want us to be accused of being too sanitised here, so Jane, I'm going to push you firmly under the bus. I have a question here asking you to comment on what you think the mental health message has been from our state and federal health departments. Do you think it's been adequate, or retrospectively, what might you have changed, or prospectively?
Thanks so much. Look, in my opinion, and it is only my opinion, I think the early messages were insufficiently informed by any understanding of the psychological impact. So many of them were authoritarian and prescriptive and quite critical of the community and quite punitive. And I think that to some extent influenced the lack of compliance. I think we have heard recently messages that are more characterised by empathy, more recognition of what it's like for people, what it is they're being asked to relinquish in service of the public good. And I think those messages that combine empathy with clear information are most likely to be effective in bringing about behaviour change. The main mental health message, I think, to date has been to seek care. And that is a good thing. I wouldn't disagree with that. But I think we now need a much more comprehensive approach, which is more sophisticated, more informed by an underpinning understanding of what the experiences are. And I think this needs to be broader than the health sector and needs to include wider community consultation. So I hope that we advance in that way pretty rapidly.
Great. Annika, to you, particularly in the disease that you have focused on tonight, interprofessional care is absolutely critical for your patients. Somebody's interested to hear you comment on what you think the impact of the whole pandemic has been on the shared care delivery model that is as so critical in MS and many other chronic diseases.
I think the impact of and the loss of that connectivity and using multidisciplinary care has had a huge impact on people with chronic diseases. I think many of our allied health professionals has also pivoted to telemedicine, but it's certainly not the same. And many of these specialties require, physical assessment and hands-on therapy to maintain people's health and improve certain levels of function as well. I think here we do need to again try and make the best with what we have and also innovate using these resources. So one of the big advantages is that I've noticed where what we can do now is, for instance, very quickly join into a telemedicine appointment that one of our patients might be having with the physio or the OT or the psychologist, even if that's required. So you can actually deliver that sort of hands-on multidisciplinary care, quite quickly if you need to. But it does require people to think about that a bit more. I think it is, of course, very much more challenging for people not in public hospitals or in big centers. So I think that private practitioners or solo practitioners might find this a lot more challenging. I think the impact of this is still going to be quite long lasting, and we'll have to see how people recover from this.
Great, thank you. Merlin, given the role of the immune system, particularly in some of the more adverse outcomes with COVID-19, what's your thoughts on the possibility of the vaccine inducing immunological damage rather than protective responses in subsets of patients?
This has been certainly a concern for some people regarding a vaccine. For example, vaccines developed against dengue and also those tested against the original SARS. In animal models, at the very least, the inflammatory response led to a worsening outcomes rather than an improved outcomes. So there was some concern that you would see what's called potentiation from a vaccine against the current coronavirus. There doesn't seem to be any evidence for that at the moment from any of the models that I've seen, but certainly it's something to watch very closely. And the idea that you can simply do a phase 1 study as they've done in Russia and then immediately go into a large population-wide vaccination program, although it might work, it is fraught with danger. And one of those dangers may be the issues regarding safety and potential for what's called potentiation.
Great. So Julian, given the level of expertise that you've assembled and the consideration you're giving to evidence-based, why can't this permeate out into a community where there remain COVID skeptics, vaccine skeptics, and so on? How can your group, which is obviously elite in terms of its synthesis of the data, have more of a community impact?
Yeah, that's a great question. I don't think any of us are naive to the fact that we can't extinguish completely those contrary voices, so the skeptics, etc. But I think it's certainly true that, particularly in this time, actually, what we've seen is the role that experts can play when they're talking clearly and directly to the public regarding the science and what we know and what we don't know. So I would encourage really everyone who does understand the science and does believe in the science to be vocal, to be contributing to the conversations in constructive ways. We see it play out, unfortunately, along political lines at times. I think we're seeing hydroxychloroquine as a sort of like a soap opera drug at the moment, where for some reason, you know, it's been caught up in these kind of partisan politics, culture wars, even though there are other drugs that are effective and other drugs that are being explored. Now, of course, we know there are some root causes to that lie across the Pacific Ocean. But you know, those kind of influences are very difficult to counter in our world now, in the world of 24-hour news cycles and social media. But I think it's really a responsibility for all of us to try and fight the good fight and address that wherever we're seeing that misinformation spreading.
Okay, thank you. Jane, there's a lot of interest in what your thoughts would be on the different mental health effects across different ages. So you highlighted some groups that have been particularly affected, women and people who've lost their jobs and so on. People are interested in the effects on both youth, children, and the elderly, and so they'd be welcome your comments there.
Well, thank you very much. And if I could just take the opportunity to completely support what Julian has said, which is to take every opportunity to speak directly to people in the community. I think that's invaluable. What we found is that young people are undoubtedly experiencing a lot of distress associated with this, but it's not all young people. And the young people who are most vulnerable are those in poorer rural communities who have not got meaningful training and who've not got opportunities to work. So I think it's not just an age group, it's an age group and then particular characteristics of people within it. What we found was that in general, people in their 60s and 70s were the least distressed. Now, this is partly, I think, because they're less likely to have responsibility for the care of young children. And it is, I think, likely that they're probably better resourced by the time they're at that age. They've got secure housing, perhaps not having to manage mortgages. But there is, to me, an element of life experience, and that if you've lived through difficult times in your life, you know that ultimately these resolve. And I think that that's what we're seeing with older people, is they've got more life experience to call on. They don't perhaps allow themselves to catastrophize. They can think of constructive things that are satisfying to do with their daily lives. So in our response, I think we do have to be very considerate of the needs of some young people, some women, some older people, but we shouldn't oversimplify this and say all young people are at risk or all women are at risk. I don't think that's a helpful response. Thank you.
Okay. So Annika, a question's been raised about clinical risk and assessment of disease versus COVID exposure, which I know many of us have grappled with over the journey. So I think people are interested on you to expand as to how you make that assessment on when you think a patient's attendance or treatment becomes an imperative over a risk of COVID exposure.
I think the main thing I think that's helpful there is having that long-term relationship with a clinician. So the thing that I found most helpful is knowing what someone has, how someone's disease has been behaving over years sometimes, and really giving you the ability to assess what the risk would be if, say, an MRI is missed or a blood test is missed, based on the probability of, the side effect or the problem that you're monitoring for. However, I think we have generally been very encouraging for people to continue with their appointments where they have to come in for tests, where they have to have pathology tests, and where they have to have treatments, because we just do not know how long this is going to last. And we cannot indefinitely delay tests, hoping that, we might get back to it in September. Ultimately, there is going to be a bottleneck when all these things are happening. So I think, it does come down to the individual person, what their disease has been behaving like, and then the clinician's judgment, really. There's not really any specific rules around it.
Okay, thanks. Merlin, questions about durability of the immune response with patients who've previously been infected with COVID showing frighteningly low levels of antibody still present only some relatively short period of time, a few months after the infection, and what the implications for this might be for successful vaccination. Mute.
These are all really important scientific questions. What we don't know is that if antibodies disappear, that there isn't some memory still pre-existing within the body that can kick in should another virus like SARS come by. I think that the idea that the absence of antibodies correlates with the absence of immunity, I don't think is going to be true. I think that there's going to be some level of priming of the immune system. What is also clear is that some of the subunit vaccines are needing more than one dose to get things going. And this might also reflect the kind of infections people have as well, that they have relatively low levels of virus that are cleared relatively quickly, and means that maybe they aren't primed the same way as someone with a very severe illness. But certainly those that do survive and do have very strong antibody responses. There's some interesting data regarding convalescent plasma in patients. But again, the data is very observational. It's only been used in experimental setting, and Julian can tell you, the level of evidence suggests that it's only an experimental therapy at this moment. And that's what we really have to do. We have to experiment. We need to support the science. We need to find the right answers, and then Julian can synthesize it all so that the clinicians and the general public and the parliamentarians can focus on the right agents for the right reasons.
Great. All right, Julian, it's time to your turn to go under the bus. So we have a question here of somebody saying, in view of this pandemic and the likelihood for future pandemics, is it time for Australia to establish formally a Centre for Disease Control, a CDC type setup, which exists obviously in the United States?
Yeah, no, it's a great question, and one that's been around, I think, for decades. I think, regardless of whether we had a centralised agency or our current more distributed, federated system, I think the key thing is that Australians can be proud and reassured that we have an extremely strong public health and infectious disease community in Australia. And obviously I say that as an infectious disease physician, but I think it's true in terms of international comparisons, given the size of country that we are. We do have extraordinary depth and breadth in the expertise that's relevant to a pandemic such as this. So I would say following this pandemic is certainly a time for governments and others to be reviewing that architecture not just in terms of the specific disease response, but of course, all of the kind of policy architecture that we have available to prepare for future stresses and threats like this pandemic. And that would also include, consideration about whether we should have a more centralized model such as the CDC. But regardless, we have outstanding talent and depth here in Australia.
Great, thank you. Jane, given that the majority of information about mental health has come from a questionnaire type scenario, and that questionnaires, as we know, have relatively modest responses, how much do you think we've underestimated the level of mental health damage that has been inflicted on our community by COVID?
Look, it's a really good question, and the questioner is accurate in saying that questionnaires, self-report instruments have limitations. I think the main limitations to date is that they've not been inclusive of people who don't speak English confidently, who don't have access to the internet or aren't confident in using it. And they are more likely to be members of groups who are likely to be experiencing considerable distress. So people who have fewer resources, who are living in crowded housing like the public towers that we've been hearing about in Melbourne. So I think there is, of course, a risk that we have underestimated the burden being carried, and we've not characterised it well for groups who are not able to participate. It's also possible we've overestimated it, and we are having to answer this question. Is it that people who are particularly concerned about this problem are more likely to have filled in questionnaires or told us about their experience? Interestingly, data are now emerging from other countries. There have been recent papers from Italy, the United States, Britain, France, all of them finding very similar prevalence. So to me, that's saying we don't have the precision of a biological test, and mental health is not an easy binary that you can say you've got a problem or you haven't got a problem. But I think we're not far out of the ballpark, and that, as Julian's reminded us, we've got to be qualified in what we say. But I feel confident enough in the data that we can say there is a public mental health problem, and we do need a public mental health response to it.
Okay, fabulous. All right, Annika, I think you might have the last one for the evening. Given the very worrying circumstances that have emerged in New Zealand in the last few days, where after 100 days of no cases, suddenly a cluster's emerged from an unknown source, I think the concern is that this virus is likely to be around at some sub-threshold level for a long time. What do you think the implications are for people with autoimmune disorders, or particularly those with autoimmune disorders on immunosuppressive therapy, with this potential background of virus amongst us?
Well, look, I think the news, there's, I guess the first thing to say is that there are very big global data collection efforts that that's happening for every autoimmune disease at the moment. So we are hoping that there should be much more clearer answers for people really soon in the next few months. And, Julian it'll come across his desk, I'm sure. But basically, thus far, the evidence in a disease like MS has been quite reassuring in that people don't appear to be at an increased risk of catching the virus. And in people who do catch the virus, they do not appear to have an increased risk of a severe or a terrible outcome, unless they have the same risk factors that we see in other populations. So very advanced age, or severe and other comorbidities like heart problems and lung problems and so forth. So for most cases, and I think for most autoimmune diseases, that would be quite similar. But what we don't know is if there's a difference between specific drugs and if there are specific people that may be at an increased risk. And because these diseases are quite rare, we need much more data and bigger groups of people over time to study this properly. And that's why you need global studies to do this, because the incidence of these diseases or the prevalence is not very high in individual countries. So we do need to work together to try and answer the more detailed questions.
Okay, thank you. All right, I think we've worked our panelists hard enough. I just would like to thank them on your behalf. Jane, Annika, Merlin and Julian for your preparation, presentation and question answering. Very grateful. And to our participants, we had fantastic questions coming in, so I congratulate you all on the quality of questions that came, and I hope that you found the webinar informative for you. And just finally, thanks again to Shelley and Emma for all the work they've done. A number of our speakers mentioned that the work has been supported in part by community donations to the university. And again, I'd like to thank those people, but feel free if you'd like to join their throng. There's opportunity for donation to support the COVID research at the university. And as you've heard from all the investigators, they would gratefully receive funding to help the funding that they can acquire from governments, etc. So again, thank you all for coming. I think it's been an educational and fascinating night. I've certainly learned a lot. I hope you all have. And on behalf of Monash University, good night and thank you.